We spend, what, like a third of our lives asleep? It's kind of wild. Yet for something so basic, defining it, explaining how it all works, it's surprisingly complex. And when sleep goes wrong, it's not just about feeling tired, is it? It can really mess up your thinking, your health, everything.
Oh, absolutely. It's fundamental. If you can't get through those normal restorative sleep periods, it's linked to just a huge range of health problems. So today, we're doing a deep dive. We're going right into the source material to really understand the nuts and bolts of the sleep-wake cycle. Our mission really is to help you connect the dots, see the symptoms in a patient and link them back to what's actually going wrong underneath, the pathophysiology.
Right, like connecting hypocritin deficiency to narcolepsy or airway collapse to sleep
It's
apnea.
synthesizing that essential knowledge.
Okay, so the plan is, first, the basics, the neurobiology, how the brain manages sleep. Then we'll get into the common sleep disorders. And finally, we'll touch on how sleep isn't static, how it changes as we get older in kids and older adults. Let's kick off with part one, the neurobiology of sleep.
Okay, so start simple. We've got two main states, right? Wakefulness and sleep. Wakefulness, that's when you're mentally active, processing senses, burning energy, making memories.
Standard daytime stuff.
Pretty much. Then sleep. That's the flip side. It's about inactivity, yeah, but focused inactivity. It's for restoration, mental and physical. Think of it like a controlled shutdown. Muscles slow down, digestion chills out, important hormones get released. It's active maintenance.
And the control center for all this. It involves quite a few brain parts working together, doesn't it? We're talking thalamus, cerebral cortex, bits of the reticular formation down in the brainstem.
Right, the midbrain, pons, brainstem, those areas are key. And this term you mentioned, the thalamocortical system, that's central.
Okay, so what is that exactly? You said it's like a loop, a two-way street. Is it like the main info highway between the sensory relay, the thalamus, and the main processor, the cortex?
That's a perfect analogy. The thalamus is like Grand Central Station for sensory info heading to the cortex. And for sleep to work properly, this whole thalamocortical highway needs careful traffic control from centers like the reticular formation. Smooth traffic flow, you get synchronized brain activity, good sleep, traffic jams, congestion. That's where the problems, the pathology start.
And we can actually see this traffic flow, in a way, using an EEG, right? The electroencephalogram. It measures the combined electrical buzz from tons of cortical neurons, not just one. So instead of just listing hertz and frequencies, how can we, get a feel for what these brain waves mean?
Okay, think of it like this. When you're awake, focused, maybe reading or problem solving, your brain's firing on all cylinders. Lots of fast, low amplitude waves. That's beta. It's kind of noisy, desynchronized.
Busy brain.
Exactly. Now, close your eyes, relax, maybe meditate. The brain settles down into a calmer, more regular rhythm. That's alpha, like a smooth, steady engine idle.
Okay, I can picture that.
Then, as you drift off to sleep, things slow down, but the waves get bigger, higher amplitude, first theta, then the really slow, large delta waves in deep sleep. This slowing down and synchronization, that's what defines the different stages of sleep.
And these wave patterns help us divide sleep into two main types. NREM, non-rapid eye movement, and REM, rapid eye movement. They cycle through the night roughly every 90 to 110 minutes, you said?
Yeah.
And NREM is the bulk of it.
Yeah, about 80% of your sleep time is NREM. It's
Yeah.
often called slow wave sleep. It's the quiet phase mostly. Stage 1 NREM is super brief, just a transition, maybe a few minutes. You're easily woken up here, like a door closing quietly, you might do it.
Is this where those weird twitches happen?
Yes. The source mentions hypnic jerks, that sudden muscle spasm. Sometimes you feel like you're falling.
Totally had that.
Yeah, it's common. It's like your brain is just teetering on the edge of sleep and gives a little jolt.
Okay, so after that brief, stage 1.
You drop into stage 2. This takes up a good chunk of the night, maybe 10, 25 minutes per cycle initially. The EEG is mostly theta waves, but you see these interesting bursts of high-frequency activity called sleep spindles.
Spindles, what are they for?
Well, the thinking is they're really important for memory consolidation, integrating new information you learn during the day. So sleep isn't just passive rest, it's actively processing things.
Fascinating. Then it gets even deeper.
Right. Stages 3 and 4. This is proper deep sleep, dominated by those big, slow delta waves, waking someone up from here. Really difficult. And physiologically, this is where the major physical restoration happens. Heart rate drops, blood pressure goes down, gut activity slows right down, deep system reset.
And then after that deep dive, things get weird with REM sleep, the paradoxical sleep.
Exactly. Paradoxical is the perfect word because your brain activity suddenly looks like you're awake again. beta waves, high activity, cerebral metabolism even ramps up, maybe 20% higher.
But you're asleep.
Totally asleep. And here's the paradox. While your brain is buzzing and you're often having vivid, sometimes totally bizarre dreams, your body's muscles, except for your eyes and diaphragm, are essentially paralyzed. Atonia.
Wow. So active mind, inactive body.
Precisely. And it seems crucial. You miss out on REM. Clinically, people get anxious, irritable, can't concentrate at all.
Yeah, I've definitely felt that after a bad night. It messes up your whole next day.
It really does. It seems vital for emotional regulation, that kind of mental cleanup. Looking at a typical night pattern, you go down through the NREM stages, 1, 2, 3, 4, then you pop back up, usually skipping stage 1, and hit your first REM episode, which is often quite short. As the night goes on, you spend less time in stages 3 and 4 and more time in stage 2 and REM, so those later sleep cycles are dominated by lighter NREM and longer dream periods.
And this whole intricate dance is timed, isn't it?
Yeah.
By our internal clock, the circadian rhythm, circadian, about a day.
Exactly. It's all about organizing our biology to fit the 24-hour light-dark cycle of the planet. Adaptation. The master pacemaker is a tiny spot in the hypothalamus called the suprachiasmatic nucleus, or SCN.
Okay, SCN. What's it about?
It gets direct light input from your retinas. So when it's light out, the SCN fires actively. When it's dark, it quiets down. Now, interestingly, our natural internal clock often runs a bit longer than 24 hours, maybe 24.2 or something.
So we drift later every day without.
Without light. Daily light exposure, especially in the morning, resets the clock. It synchronizes it to the actual 24-hour day. That process is called entrainment.
Ah, entrainment. Okay. And this SCN also controls hormones, like melatonin.
Yes, it directs the pineal gland to produce melatonin. Production ramps up in the evening, peaks overnight, and drops off in the morning. It signals darkness and promotes sleep onset, which is why, people use synthetic melatonin or the prescription drug Rameltian, which hits the same receptors, to help shift their sleep timing, like for jet lag or shift work.
Right. Okay, that sets the stage for the biology. Now, what happens when this system goes off track? Let's talk about diagnosing sleep disorders. It sounds like getting a good story from the patient is step one, a detailed sleep history.
Absolutely crucial. You need the basics. Bedtime, wake time, how long it takes to fall asleep, any night awakenings, naps. But also, how do they feel during the day? Fatigued? Irritable? Can they concentrate? And you have to ask about the sleep environment. Noisy? Too bright? And critically, substance use, caffeine, nicotine, alcohol, medications, they all impact sleep.
Makes sense. Beyond the history, what tools do we use?
Well, there are a few key ones. For tracking patterns at home, a sleep log or diary for at least 2 weeks is really helpful, just writing it all down. Then there's actigraphy. It's like a Fitbit, basically. Worn on the wrist or ankle, it tracks movement. It's not direct sleep measurement, but gives a good estimate of sleep time and efficiency outside the lab.
And for the really detailed look, the sleep study.
That's polysomnography, the PSG. That's the overnight lab test. It's comprehensive. You're hooked up to an EEG for brainwaves, EOG for eye movements to catch REM, EMG for muscle tone, plus ECG for heart rhythm, pulse oximetry for oxygen levels, airflow sensors, the works.
Wow, okay. And what about specifically measuring daytime sleepiness?
For that, we use the multiple sleep latency test, or MSLT. This happens during the day, usually after a PSG. You're given several opportunities to nap about 2 hours apart. They measure how quickly you fall asleep, the sleep latency. Falling asleep in less than, say, 8 minutes on average. That's considered abnormally sleepy.
Got it. So let's use that diagnostic framework to look at specific disorders. First up, the ones where the timing itself is the core problem. Circadian rhythm sleep-wake disorders, or CRSWDs.
Right. This is when your internal SCN clock is just out of sync with what the world demands: work, school, social life.
Probably the one many listeners, especially younger ones, might recognize is delayed sleep-wake phase disorder, DSWPD, the classic night owl.
Exactly. Difficulty falling asleep until, say, 2 or 3 a.m., and then real trouble waking up for a 9 a.m. class or job. And it might not just be preference. The source material suggests puberty might actually stretch out the natural circadian period length a bit, biologically pushing teenagers towards that later schedule.
Interesting. And there are other timing issues, too.
Oh, yeah. Like non-24-hour sleep-wake rhythm disorder, N24SWD. Here, the person's internal clock isn't synchronized at all to the 24-hour day. It just drifts later and later. This is really common in people who are totally blind, maybe 50–70% of them. They don't get that light input needed for daily entrainment. Treatment involves reinforcing light-dark cycles if possible, or using melatonin agonists like tasamelteon.
And things like jet lag and shift work. They fall under this umbrella, too.
Definitely. They're acute shifts. Jet lag is temporary misalignment. Interestingly, flying eastward is harder. You need to advance your clock, go to bed earlier, which our bodies resist more than delaying sleep by flying west.
Hmm.
Shift work is tougher because it's often chronic misalignment. Your light cues from work lights are fighting with the natural daylight cycle and your social routines. It's a constant battle for the SCN.
Okay, shifting gears from when people sleep to if they can sleep, let's talk insomnia, the big one.
By far the most common sleep complaint. For a diagnosis of chronic insomnia, the key criteria are difficulty falling asleep, staying asleep, or waking up too early, despite having adequate opportunity to sleep. And crucially, it has to cause significant daytime problems, fatigue, mood issues, trouble concentrating, and it needs to persist for at least 3 months, 3 nights a week, or more.
And it's often linked to other things, right? Not just happening on its own.
Very often. Chronic insomnia frequently travels with other medical conditions. Think chronic pain, heart failure, restless legs, or psychiatric disorders like depression and anxiety. Plus, don't forget drugs and substances. Caffeine, nicotine are obvious stimulants. Alcohol might make you drowsy initially, but it fragments sleep later. Even some antidepressants can be activating.
And what about short-term insomnia?
That's usually called acute insomnia, less than 3 months. Often you can pinpoint a trigger, a major life stressor, losing a job, a death in the family, even just being in an unfamiliar place like a hospital ICU.
So how do we treat insomnia? Is it just sleeping pills?
Actually, no. The first-line approach, especially for chronic insomnia in adults, isn't medication. It's about behaviors and thoughts. Basic sleep hygiene helps consistent wake-up time, cool, dark, quiet room, avoiding caffeine and alcohol late in the day. But that's often not enough for chronic cases.
So what's next?
Cognitive behavioral therapy for insomnia, or CBTI. This is considered the gold standard. It has several components. One is sleep restriction. Sounds counterintuitive, but you actually limit the time spent in bed to more closely match the actual time spent asleep. This builds sleep drive and improves efficiency. Another key part is stimulus control. This is about breaking the association between the bed and frustration or wakefulness.
Yeah.
Rule is, bed is only for sleep and sex. If you can't fall asleep after, say, 20 minutes, get up, do something relaxing in dim light, and only go back when sleepy.
Retraining the brain's association with the bedroom.
Precisely. Medications like BZRAs, think Zolpidem, are used, but there are concerns about dependence and side effects. Ramelteon, that melatonin agonist we mentioned, is interesting because it's non-scheduled, FDA approved for long-term use, specifically for trouble falling asleep.
Okay, let's flip to the other extreme. Excessive sleepiness. Narcolepsy.
Right, a disorder of hypersomnolence. The definition involves an irrepressible need to sleep, or daytime lapses into sleep, happening consistently for at least 3 months. Daytime sleepiness is usually the first and most prominent symptom.
And type 1 narcolepsy has that really distinct feature, cataplexy.
Yes, cataplexy. These are brief episodes of sudden muscle weakness, often triggered by strong emotions, laughter, surprise, anger. Knees might buckle, head might drop, speech could slur. It's REM paralysis intruding into wakefulness.
So what's the underlying cause here? The pathophysiology.
It's fascinating. It boils down to a problem with REM sleep regulation. Specifically, in most type 1 cases, there's a profound loss of brain cells that produce hypocretin, also called orexin. Hypocretin is a crucial neurotransmitter made in the hypothalamus that promotes wakefulness and stabilizes the sleep-wake switch.
And why are those cells lost?
The leading theory is an autoimmune attack. It's strongly associated with a specific genetic marker, HLA-DQB10602, suggesting the immune system mistakenly targets those hypocretin-producing neurons, often after some trigger like an infection.
So it's an autoimmune neurodegenerative process, essentially.
That seems to be the case for type 1. Diagnosis often relies on that MSLT we talked about, showing very short sleep latency, falling asleep super fast during naps, and often entering REM sleep very quickly during those naps, which is abnormal for daytime sleep.
Treatment isn't curative then, it's managing symptoms.
Exactly. Scheduled naps, good sleep hygiene are foundational. Then stimulant medications like methylphenidate or modafinil are used to combat the daytime sleepiness. Specific meds can help with cataplexy too.
Okay, let's move to things that disrupt sleep through movement. Sleep-related movement disorders.
These often pop up during the lighter stages of NREM sleep, 2 main ones to know.
First is periodic limb movement disorder, PLMD.
Right. Repetitive movements, usually involving flexing the big toe, ankle, knee, maybe even the hip. Happens during sleep, often in bursts. The person sleeping is usually totally unaware. It's the bed partner who complains about being kicked all night.
And the other big one is Restless Legs Syndrome, RLS. Sounds similar, but it's different, right?
A very different experience for the patient. RLS happens while awake, usually in the evening or when trying to fall asleep. It's defined by four key features. One, an overwhelming urge to move the legs, often accompanied by creepy crawly or uncomfortable sensations. Two, it starts or gets worse during rest or inactivity. Three, it gets better with movement like walking or stretching. Four, it's worse in the evening or at night.
That urge sounds awful. What
Yeah.
causes RLS?
The mechanism isn't fully nailed down, but there's a strong link suggested with how the brain handles iron. Iron is essential for making dopamine, a key neurotransmitter. So dysfunction in dopamine pathways, possibly related to low brain iron levels, even if peripheral iron is normal, seems to be involved.
Which explains why treatments often target dopamine.
Exactly. Dopamine agonists like ropinirole or pranopexole are common treatments, along with iron supplementation if levels are low.
Yeah, for a major one, often linked with serious health consequences. Sleep-related breathing disorders, particularly obstructive sleep apnea, OSA.
Yes, OSA is the most common type of sleep-disordered breathing. Apnea just means cessation of airflow specifically for 10 seconds or more. It's crucial to distinguish obstructive apnea, where airflow stops despite ongoing effort from the respiratory muscles, chest and abdomen are still moving, from central apnea, where the brain just doesn't send the signal to breathe, so effort stops too. We're focusing on OSA here.
So what's happening mechanically in OSA?
Yeah.
Can you walk us through that,
Right.
like describing figure 17.6 from the text?
Sure. So picture the throat, the pharynx. When you fall asleep, most skeletal muscles relax, including the muscles that normally hold the upper airway open. At the same time, your diaphragm contracts to pull air in. This creates negative pressure. If those upper airway muscles are too relaxed or the airway is naturally narrow, that negative pressure sucks the pharyngeal walls inward and the tongue can fall back, completely blocking the airway. Poof! Obstruction.
And who's most at risk for this collapse?
Key risk factors are male gender, getting older, having a family history. But the big one, the major modifiable risk factor, is obesity. A large neck circumference, the source gives a figure of greater than 40 centimeters, about 16 inches, is highly predictive of OSA. Excess tissue narrows the airway.
And clinically, what does this look like? Chart 17.2 mentions symptoms.
The classic triad is excessive daytime sleepiness, loud snoring, often with pauses or gasps reported by the partner, and waking up feeling unrestored, maybe with a morning headache. But the really dangerous part is the downstream effects. Each apnea causes oxygen levels to drop and triggers a brief arousal to reopen the airway. This constant cycle stresses the cardiovascular system. You get surges in sympathetic nervous system activity leading to hypertension, increasing the risk of cardiac arrhythmias, heart failure, even stroke. It's serious.
So how do you treat it? Stop the airway from collapsing.
That's the goal. Lifestyle changes like weight loss and avoiding sleeping on your back can help mild cases, but the mainstay, the primary treatment, is CPAP, continuous positive airway pressure. It's a machine connected to a mask worn over the nose or face. It delivers pressurized air that acts like a splint, physically holding the airway open during sleep.
Effective, but maybe not the most comfortable thing.
Compliance can definitely be an issue. There are alternatives like oral appliances that reposition the jaw or surgery in some severe cases, but CPAP is generally the most effective, non-invasive option.
Okay, one last category of disorders. The parasomnias. These are the weird behaviors that happen during sleep.
Right, undesirable physical events or experiences, things like nightmares, sleepwalking, sleep terrors.
Let's distinguish those. Nightmare disorder.
These are vivid, scary dreams that usually happen during REM sleep, often later in the night. The key is that the person typically wakes up fully alert, remembers the dream vividly, and feels distressed. Common in young children, but also a hallmark symptom of PTSD in adults, where the nightmares often involve reliving trauma.
Okay, so REM sleep, remembered content.
Yeah.
How does that differ from sleepwalking and sleep terrors?
Big difference is the sleep stage. Sleepwalking, somnambulism, and sleep terrors occur during deep NREM sleep, stages 3 and 4, usually in the first third of the night when delta sleep is most prominent. And the person is not fully conscious and typically has no memory or only fragmented images of the event afterward.
Describe a sleep terror. Sounds dramatic.
It is. It's often a sudden piercing scream or cry. The person sits bolt upright, looks terrified, heart racing, sweating major autonomic activation. But they're unresponsive, inconsolable, and again, won't remember it in the morning, mostly seen in kids.
And sleepwalking.
That involves more complex automatic behaviors. Getting out of bed, walking around aimlessly, sometimes even dressing, opening doors, going outside. They look dazed, glassy-eyed, unresponsive. The main concern here isn't the behavior itself, usually, but the risk of injury falling downstairs, walking into things.
Makes sense. Safety is key for those NREM parasomnias.
Absolutely, especially since both sleep terrors and sleepwalking are most common in children and tend to resolve by adolescence.
Okay, that brings us nicely to part 3. Sleep across the lifespan. Let's start with kids. How does their sleep develop?
It evolves rapidly. Circadian rhythms start to emerge around 2, 4 months old. Newborns sleep a ton, like 16, 20 hours a day, but it's not clearly organized into adult stages yet. They have active sleep, which is kind of like REM, taking up about 50% of their time, quiet sleep like NREM, and an intermediate state. Distinct NREM stages solidify by about 6 months.
And the sleep issues parents usually complain about in kids,
Yeah.
besides just getting them to sleep.
Yeah, often it's those parasomnias we just discussed. Sleep terrors can be really frightening for parents to witness, but they typically resolve. Confusional arousals are similar. The child wakes up partially, seems very confused, maybe cries, slow responses, but again, no memory. Also NREM based. And sleepwalking is quite common. Peak age maybe 5, 12 years. Usually goes away by puberty. Main management is just safety precautions, locks on doors and windows, clearing floors.
Okay, now let's shift to the other end of the spectrum. Older adults. You hear a lot about sleep problems in seniors.
It's very common. Over half of adults over 65 report some kind of sleep difficulty. But it's important not to just chalk it all up to getting old. While there are age-related changes, often the sleep problems are driven more by coexisting medical conditions, psychological factors, or medications.
So what are the typical age-related changes?
Sleep tends to become more fragmented, more frequent awakenings during the night, longer periods spent awake in bed. Total sleep time might decrease slightly, but the bigger change is in the architecture. There's a noticeable reduction in the duration of deep NREM sleep, stages 3 and 4, and also less REM sleep. Sleep efficiency, the percentage of time in bed actually spent asleep, often decreases.
And the comorbidities that interfere.
Oh, a long list. Physical illnesses causing pain or discomfort, like arthritis, cardiovascular disease, neurological conditions like Parkinson's, which disrupts sleep regulation, psychiatric issues, especially depression, even just needing to get up to use the bathroom frequently, nocturia. And polypharmacy is huge. Many common medications like certain antidepressants, decongestants, steroids can interfere with sleep. Plus, primary sleep disorders like insomnia, OSA, and RLS actually become more common with age, too.
So it's often a complex mix of factors.
Exactly. And it matters because chronic sleep problems in older adults aren't just annoying. They significantly increase the risk for falls, accidents, cognitive decline, and really impact overall quality of life. Addressing sleep is crucial for healthy aging.
Okay, that covers a lot of ground. Let's try to pull the key threads together one last time. A quick recap.
Sure. So we've seen sleep isn't just off. It's a vital, actively regulated restorative state. It's governed by complex brain circuits, the SCN setting the daily rhythm, the thalamocortical system managing brain activity. We cycle through distinct phases. NREM for deep physical rest and maybe memory consolidation, and REM for, well, dreaming, emotional processing, something crucial but still a bit mysterious. And pathophysiology, the disease mechanisms kicks in when this system gets disrupted. Maybe the timing control fails, circadian disorders, or a key chemical is lost, hypocretin in narcolepsy, or a physical structure blocks function, airway in OSA.
Right. So what does this all mean for you, the listener? I think the key is that understanding these mechanisms helps you differentiate. You can see the difference between, say, normal sleep becoming a bit more fragmented as someone ages versus a potentially treatable disorder like RLS, which might be linked to iron metabolism, or OSA causing dangerous oxygen drops. Knowing the why behind the symptoms points towards effective management.
Absolutely. It connects the clinical picture to the underlying biology.
And maybe one final thought to leave folks with.
Okay, consider this. Our internal circadian system seems pretty hardwired for that stable 24-hour cycle. We see how much our bodies resist sudden changes, like in jet lag or shift work. Given that resistance, what might be the deeper long-term health costs? Maybe ones we haven't fully quantified yet when our modern society constantly asks us to override that biology. Through things like chronic night shifts, constant exposure to artificial light, pushing against our natural rhythms day after day, what's the cumulative toll?
Something to think about for sure. On that note, a warm thank you from the Last Minute Lecture team.